hormones, right? So can anyone tell me what is a gonadotropin releasing hormone? Anyone?
The leproid, and it's
So
ghrelin.
what? So basically, first of all, let us come to the thing. What is a GnRH?
It's the hormone secreted by the
Gonadot
hypothalamus that acts on the anterior pituitary to secrete luteinizing hormone and follicular stimulating hormone, which act on the
Okay,
gonads.
right. So GnRH is that hormone which acts on the pituitary to secrete follicle stimulating hormone, that is FSH and LH, right? So the first most important thing that you need to remember about GnRH is its duality of nature, right? So the release of GnRH is pulsatile in nature. So it does not secrete, so it is not secreted or it does not act in a continuous way. It is secreted and then there is some stop, and after some time it is secreted again. In this way, GnRH increases the release of FSH and LH. But if GnRH is used in a continuous way, it will decrease. It will first increase FSH and LH, but after some time, the FSH and LH will drastically decrease, right? So then, when FSH and LH decreases, the testosterone and estrogen will decrease. So that is how what this is what the mechanism of GnRH is. So we can use GnRH to upregulate FSH and LH, and at the same time we can use GnRH to downregulate FSH and LH as well. So what will be the conditions in which we use GnRH releasing analogs in a in a pulsatile way? So any condition in which we need to increase testosterone, for example, if we have some kind of infertility, or if we want to do pregnancy, or so then we will do pulsatile release of GnRH, right? But if we are treating any kind of cancer, such as such as the prostate cancer. Because remember, the main mechanism by which prostate cancer grows is by the formation of androgens such as testosterone, which acts on the prostate and it causes the prostate to grow. So we give GnRH in a continuous way to decrease FSH and LH, and then testosterone will decrease. And when testosterone decreases, then the growth of prostate will decrease as well, and the cancer won't grow as much as possible, right? So again, in precocious puberty, we use GnRH analogs as well. So in precocious puberty, testosterone and estrogen has increased. So in order to decrease them, we use GnRH analogs continuously, so as to decrease the release of testosterone and estrogen and really reduce the precocious puberty. Again, in endometriosis, we do the same thing to to reduce the to reduce the amount of estrogen and testosterone. And in uterine fibroids, we can use GnRH as well. Okay, so what is the most important risk factor regarding GnRH use in a continuous way? Anyone?
sir, basically it's used for cancer, so risk factor.
So, so what is the major side effect of the use of GnRH?
The hypogonadism.
No
Okay.
ovulation.
Any other? So these are the things that are obvious. Like it will cause hypogonadism. It will decrease the libido because it is decreasing testosterone and estrogen. It could lead to erectile dysfunction. Nausea and vomiting are really not that important, and you can even strike them out because they are not going to test you on nausea and vomiting as a side effect of GnRH analogs. So what is another important side effect that is not mentioned in first aid? And that is the most important side effect of GnRH analogs.
Osteoporosis.
Yes, exactly. So remember, guys, whenever a condition decreases the estrogen, any condition that decreases estrogen, for example, premature menopause, primary ovarian failure, or GnRH analogs, which decreases the estrogen level in the body, or Turner syndrome. So remember, in any of these conditions, since estrogen is decreased, their bone turnover will increase and the patient will have osteoporosis. So that is why for the treatment of uterine fibroids, we cannot give GnRH analogs for more than 12 weeks, right? So always keep this thing in mind, whether there is whereas there is premature ovarian failure, Turner syndrome, menopause, or if you are using a GnRH releasing analog, then it would lead to osteoporosis. And now, one other thing that is important is that when you first use GnRH in a continuous way, first of all, it will increase the level of testosterone and estrogen for some time. And when the level of estrogen and testosterone increases for some time, the tumor will grow rapidly in size, or the precocious puberty, for example, will flare up rapidly, right? Or the endometriosis will flare up rapidly, or the uterine fibroids will flare up rapidly. So this thing is known as a GnRH flare. Okay, so this is a GnRH flare. So whenever a GnRH flare occurs, that is a problem for us. So to prevent GnRH flare, we use another drug which is known as Digarelix. So what does Digarelix do, guys? So Digarelix is a GnRH antagonist. So its role is very simple. It will cause no formation on a FSH. So when we start, when we start using GnRH in the start, uh, so we adjunct it with GnRH antagonists such as Gigarelix to prevent the tumor flare up. And this is a very common USMLE and NBME concept that they love to test that uh, if why do we give GnRH antagonists such as GNR Gigarelix in the start? With GNRS analogs. So that is the reason we use Digarelix to prevent any kind of a tumor flare-up which is present. Okay, so what is the most important side effect of a GnRH antagonist? So the most important side effect is it will lead to hot flashes. So it will lead to a condition in which there will be menopause-like symptoms, right? So now let us move on to the third, which is ethanol estradiol. So ethanol estradiol simply is an estrogen analog. So it works in a similar way in the way an estrogen will work. So when do we give it? If there is some kind of hypogonadism or ovarian failure or some kind of a menstrual abnormality or in postmenopausal women when there is when there are hot flashes. Okay. So this is another important topic or indication that you need to remember whenever in a postmenopausal woman, there are some kind of symptoms of menopause. When do we start hormone replacement therapy? Anyone would like to answer this question?
When the patient presents with the symptoms like hot flashes.
Exactly. So when the symptoms are of vasomotor kind, so if there are any vasomotor symptoms such as hot flashes, sweating, then we will give the woman hormone replacement therapy that is estrogen. Remember, we do not give estrogen or ethinyl estradiol for the prevention of osteoporosis in postmenopausal women. That is never an indication for the use of ethinyl estradiol. Remember, guys, they will trick you in USMLEs and BMEs and such questions, even in your USAS, your word self-assessment test, by giving you ethinyl estradiol or estrogen for the treatment of osteoporosis, but it is never a treatment for osteoporosis. For the treatment of osteoporosis or for even the prevention of osteoporosis, we give bisphosphonates. So the standard treatment for osteoporosis is bisphosphonates. What are the side effects of estrogen? So we have already covered in PCOS and endometrial hyperplasia that excess estrogen exposure can lead to endometrial hyperplasia, and that endometrial hyperplasia would lead to endometrial cancer. So another concept that arises here is, or another high yield point that comes here is, what can we do to prevent this increased risk of endometrial cancer that occurs with the presence of a hormone replacement therapy with ethinyl estradiol or any estrogen. So what we
We
can
can,
do is we can give progesterone.
yes,
So
we'll add.
progesterone will thin the endometrial lining. So I am repeating these concepts again and again because these are the main gist of the reproductive system, right? So in any case of endometrial hyperplasia, any case of high risk female in which we need to do hormone replacement therapy, we always combine progesterone with estrogen, right? And again, other things that it can lead to is if there is diethyl stilbestrol, that is another kind of estrogen that can lead to clear cell adenocarcinoma. We have already covered that. Estrogen also increases the risk of thrombi and the risk of DVT is increased. So hormone replacement therapy can lead to increased risk of DVT. What are the contraindications? If we have a hormone positive breast cancer. So if the female has a history of hormone positive breast cancer or any DVT or any smoking or uncontrolled hypertension, then we do not give them hormone replacement therapy or estrogen. Again, the contraindications of hormone replacement therapy are very, 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 very much important. So any history of estrogen positive or hormone receptor positive breast cancer, any history of DVT, any history of smoking, even any history of migraines, and any history of uncontrolled hypertension. We do not give estrogen in those patients. Okay. So this was an analog of estrogen, which was ethinyl estradiol. Now we will move on to the selective estrogen receptors. So what do selective estrogen receptors mean? So selective receptors mean that they act as an analog in some place in some of the in some receptors of the body, these compounds will act as analogs, whereas in the other parts of the body, these things won't act as an analog. Maybe it can act as a neutral compound, or maybe it can act as an antagonist. So these are three main ones. So the first one is clomiphene citrate. So clomiphene citrate is an antagonist of estrogen receptors in the hypothalamus. So is it a very logical thing that whenever estrogen is high in the body, it goes and acts on the hypothalamus. And when high estrogen acts on the hypothalamus, it decreases the release of GnRH. And ultimately, the release of FSH and LH is decreased from the pituitary. And when these things are decreased, ovulation is suppressed. So if we need to increase ovulation or fertility in a woman, due to an ovulation, or if you want to do more ovulation to increase the fertility, such as in PCOS, what do? We give the patient clomiphene citrate. So what will clomiphene citrate do? Clomiphene citrate will antagonize the hypothalamic estrogen receptor, but it just acts on the hypothalamic estrogen receptor. That is the very much benefit of this drug. It won't act on the ovaries, it won't act on the bones, because if it acts on the bone, it would cause osteoporosis. If it acts on the ovaries, it would cause the ovarian follicle not to mature, and hence the fertility won't be possible. So we just need it to act on the hypothalamus, and this is the very specialty of the drug, that it acts only on the hypothalamus, right? Okay. So another thing that comes here is I've already told you the side effect of clomiphene citrate. Then they love to ask this question: what are the main side effects of clomiphene citrate regarding pregnancies? So the main side effect is that it leads to multiple pregnancies at the same time. There will be multiple pregnancies, there will be twins, there will be triplets, there will be quadruplets, and those baby will be stillborn or they will be born dead. They won't be born alive.
Doctor,
And
is this called ovarian hyperstimulation?
yes, so what happens when it acts so much on the ovaries, it will also lead to ovarian hyperstimulation. So what is ovarian hyperstimulation syndrome? So in ovarian hyperstimulation syndrome, when so much estrogen acts on the ovaries, it will lead to an increased production of the follicles and cysts. So not one dormant major follicle will form, but instead seven or eight follicles will form. And when seven or eight follicles form, each of them will have their own water, own cytoplasm, and own glycogen, and that will imbibe water, and that would cause a lot of edema to form in the ovaries. And when ovaries will enlarge so much, we have already covered in the ovarian cancer that when an ovary is enlarged very much, or if any kind of mass is present in the ovary, it will lead to uh, constipation and um, peritoneal problems, and there will be ascites as well, right? So there will be ascites in hyperstimulation syndrome. There will be constipation. The ovaries will be enlarged as well. So all of these are the side effects of clomiphene citrate. Remember, guys, in USMLEs and in BMEs, you have to learn about the main side effects. There will be hot flashes and other side effects, visual disturbances. But regarding compensate rate, the thing they want you to test about is the multiple simultaneous pregnancies, ovarian hyperstimulation syndrome, multiple dead bone babies which are present. Okay. So the second drug is here is tamoxifen. So tamoxifen and raloxifene is very similar. We use both. So tamoxifen is used for the treatment of breast cancer. So what happens in the case of tamoxifen is that tamoxifen acts as an antagonist on the breast and it acts as a partial agonist on the uterus and the bone, right? So what will happen in this case is when it acts as an antagonist on breast, if there is any history of or if there is a presence or diagnosis of the breast hormone receptor positive breast cancer, it will cause the hormone receptor positive breast cancer to not grow, because in order for the growth of hormone receptor positive breast cancer we need estrogen there. But if estrogen cannot act because of seven antagonists, the breast cancer will go in remission. So what are the side effects of this thing? So okay, so since it acts as a partial agonist on the on the uterus, it will again lead to endometrial hyperplasia and endometrial cancer, right? And now, since it is acting on the bone as well in a partial way, that would lead to osteoporosis. Okay. So there will be risk of osteoporosis, there will be risk of endometrial cancer, and since it increases estrogen and uterus, it can lead to thromboembolic events as well. And again, thromboembolic events risk are increased in case of migraines, smoking, hypertension, and such stuff. So remember, for the treatment of breast cancer, we used tamoxifen. But what are the major side effects that they want you to know? The major side effects would be chance of endometrial cancer and the chance of osteoporosis and the chance of thromboembolic events. In order to reduce the chances of endometrial cancer, we normally give progesterone, but in this case, we cannot give progesterone because there is a positive is a cancer which is receptive to progesterone, so we cannot give progesterone, but instead we can give an IUD, a progesterone IUD which is not absorbed systemically. So they can give it in order to reduce the risk of endometrial cancer in a woman who is using tamoxifen. What therapy do will we give who is already suffering from estrogen and progesterone positive breast cancer? So remember, they will give you an option of progesterone, and at the same time, they will give you an option of progesterone IUD. And the answer would be progesterone IUD and not the progesterone. Now, the third son is raloxifene. So raloxifene is antagonist at breast and uterus, and it is agonist at bone. So it is the best of the three worlds. Why? Because first of all, it would cause the bones not to grow. Again, it will not lead to an increased risk of uterine cancer because it is an antagonist at the uterus and it is agonist at the bone. So there will be no problem in osteoporosis, but it will instead treat osteoporosis. But again, what will be the risk factors? Still, it is an estrogen, so it will lead to an increased risk of thromboembolic events. And since it is an antagonist at the uterus, and ovaries, so hot flashes will occur. So remember, if there is any estrogen, any compound that is antagonist of estrogen, always think of hot flashes as the answer. And if the same time if any compound has an analog action of estrogen, then thromboembolic events would be a risk factor in that case. Now,
Excuse me, can I
yes,
ask a
yes,
question? You said
yes, sure.
yes, you said tamoxifen that it's an antagonist at the breast and agonist at the uterus and bone. So you said since it's an agonist at the uterus, it causes endometrial hyperplasia, which yes, but on the bone, why osteoporosis if it's an agonist?
Okay, so remember, um, it is a partial agonist at the bone. It is not a complete agonist. So, what is the difference between a partial agonist and a complete agonist? So, partial agonist normally leads to increased growth. But if a complete agonist is present at the same time and a partial agonist acts at the same time, then it would lead um, to an antagonization at the bone. So, in this case, it will act as a partial agonist at the bone. So if anything is acting it as a partial agonist at the bone, it will lead to osteoporosis there because it is reducing the activity to some extent. Okay.
Okay, thank you.
Okay. Okay. Whereas in the case of raloxifene, it is a complete agonist. It is not a partial agonist. And they love to test these things, whether it is a partial agonist, it is a complete agonist. What are the effects of these things on the Michaelis-Menten constant, Km, Vmax, and stuff like that. So the third thing is aromatase inhibitors. So what are aroma? What is aromatase? So aromatase is the enzyme that converts testosterone or androgens into estrogen. So very fun fact, even in a female body, all of the estrogen comes from testosterone. So every female has testosterone in her body first, which is present in the ovary. So the first step in the in the formation of hormones is that her testosterone will form in the body of a female, and then after that, it will be converted into estrogen by an enzyme which is known as aromatase. So if we give aromatase inhibitors such as letrozole, anastrozole, or exemestane, then estrogen won't form. And when estrogen is not forming, then we get our thing done. And so what are the conditions in which we don't want estrogen? So the main thing is ER positive breast cancer. So estrogen receptor, so in estrogen receptor positive breast cancer, we give aromatase inhibitors. So again, another important question that arises when so you can say, Dr. Moss, we use tamoxifen as well for estrogen receptor positive breast cancer, but now another drug comes aromatase. Why do we need two drugs for the treatment of same disease? So there is a very big difference between these drugs, and the major difference is that since tamoxifen leads to osteoporosis, and at the same time, tamoxifen leads to an increased risk of endometrial cancer. We cannot give this drug in older aged females because in older aged females are already at increased risk of endometrial cancer and osteoporosis. So if an older aged female comes, our first preference would be aromatase inhibitors. Especially because aromatase inhibitors won't lead to an increased risk of uterine cancer. That is the major reason that we give aromatase inhibitors instead of tamoxifen in postmenopausal females. So premenopausal females and the treatment of estrogen receptor positive breast cancer, we give tamoxifen. Postmenopausal women with estrogen receptor positive breast cancer, we'll give aromatase inhibitors. Another thing where we can give aromatic inhibitors are is PCOS. And now letrozole is much more preferred than chloromethine citrate for the treatment of infertility. And how does this will help how does this help in infertility? When we reduce the formation of androgens to um, estrogen, again it will cause a positive feedback, it will lead to that negative feedback loop, which will increase the GnRH. FSH and LH will increase. When FSH and LH increase, ovulation will occur, and when ovulation occurs, then we can have a baby. Now we move on to hormone replacement therapy. Hormone replacement therapy is okay. So wait a second, let me share my screen. Hey guys, can you see my screen?
Yes.
Okay,
Yes.
sure.
Yes.
Okay, so now we move on to hormone replacement therapy, right? So so again, I have told you that hormone replacement therapy, the main indication of hormone replacement therapy is for the prevention or relief of menopausal symptoms. And again, there's a misunderstanding or a thing in first aid where it says that it can be used for the prevention of osteoporosis. Hormone replacement therapy definitely prevents osteoporosis and even treats them, but we cannot use them primarily for the prevention of osteoporosis. So you will and NMEs will give you this question, and in the same thing, in the same question, they will ask you a 64-year-old aged female comes to you, and she has symptoms of osteoporosis, and her DEXA score is -3, and then she has hot flashes and vaginal atrophy. Which of the following clinical symptoms is the most strongest indicator of an initiation of hormone replacement therapy in this patient? So that symptom would be the menopausal symptoms, right? Okay. So again, the same concept is repeated here that whenever unopposed estrogen replacement therapy is present, endometrial cancer will increase. The risk of endometrial cancer will be increased. So we add progesterone as well, and that progesterone will decrease the risk of hormone replacement therapy or endometrial cancer, right? So now let us move on to progestins, right? So again, so now progestins are the analogs which bind progesterone receptors, and then the growth and vascularization of endometrium is decreased, right? The growth is decreased and the vascularization is increased. Again, remember this thing that progesterone increases the vascularization and it decreases the growth and it thickens the cervical mucus. Okay. So what are the uses of progesterone? So the first use of progesterone is we can use it in contraception. Second thing, we use it in endometrial cancer because it reduces the growth of endometrium. For any abnormal uterine bleeding, we use it as well because it reduces the growth of endometrium, so the bleeding will be reduced. Now, regarding progestin challenge, let me tell you. Does anyone know about progesterone withdrawal challenge? Anyone?
Yes, even the
Breakthrough bleeding.
progesterone, if there is bleeding after giving, then it will not be the Asherman. Otherwise, it will be the Asherman syndrome.
Okay. So let me tell you about progesterone challenge test. You see, it is a very interesting test, right? So remember, guys, there can be many causes of amenorrhea. So amenorrhea is the condition in which a female stops menstruating and there is no bleeding from her uterus, right? So how can we know that what is the cause of her amenorrhea? So the first thing that we do to determine that is a progesterone withdrawal test. So, because remember, guys, the two main causes of amenorrhea, the number one is some kind of ovulatory defect, and the second one is some kind of anatomic defect. So, what do we do is that first of all, to differentiate between the different kinds of amenorrhea, whether it is due to anovulation or anatomic defects, we use this test. So, why do we use this test? Because in anovulation, we give because in an ovulation, no progesterone is secreted from the ovary, right? Because in order for the ovary to secrete progesterone, the ovum must be released or expelled from the ovary, and then corpus luteum forms, and that corpus luteum will form progesterone, right? Then that progesterone will lead to an increased vascularization of the uterus. So the uterus will become extremely vascularized and rich in blood supply. So after 12 or 13 days, the progesterone suddenly starts decreasing. And when there is a withdrawal of progesterone suddenly, then bleeding occurs because that vascularization cannot be supported anymore. So that progesterone is now being withheld, and then bleeding occurs in those females, right? So this is the normal mechanism of how bleeding occurs in a female.
Sorry,
But
sorry. Can you come again? Can you repeat yourself with the test?
okay, so let me tell you the normal female menstrual cycle, the second half. So in let me summarize the menstrual cycle. So in the first half of a menstrual cycle, ovum is growing, follicles are growing, aromatase is being formed, and that aromatase converts testosterone to estrogen. So what happens is that estrogen will increase the growth of uterus, and suddenly uterus reaches a maximum growth. And after that, an ovum is formed, and that ovum is expelled from the ovary. right? So when that ovum is expelled from the ovary, corpus luteum forms, and that corpus luteum secretes progesterone. So now the growth of uterus is at maximum point, and now progesterone will cause vascularization to occur. So increased vascularization will occur. It will be the peak of vascularization. A lot of blood vessels will form in the uterus, and then those blood vessels become extremely enriched with blood. So after 26 or 27 days, the progesterone suddenly stops being secreting. So when this progesterone suddenly gets stopped, then menstruation occurs, right? So this is the way how menstruation occurs. So whenever there is an anovulatory cycle, no progesterone will be secreted because no ovum is being released. And when no ovum is being released, no progesterone, no corpus luteum will be there, no growth of vascularization, no vascularization of blood vessels will be there, no engorgement of blood will be there. So no any kind of menstruation won't occur. So when any kind of menstruation does not occur, there will be no bleeding. So there will be no menorrhea and it will be known as amenorrhea. So that is one way how amenorrhea occurs. The second way is that there is some kind of anatomic defect that in which even if the menstruation occurs, the uterus is so scarred or the outflow tract is so obstructed that it won't let the bleeding or the blood to go out. So we can never be sure that even if menstruation is occurring or not occurring, because there is some kind of fibrosis, there is some kind of scarring, or the scar does not let the uterus go down, right? So this is the second way. So how do we differentiate between these two conditions? That whether it is due to anatomic difficulties or due to the absence of progesterone. So we do a test which is known as progesterone withdrawal test. In progesterone withdrawal test, we give a lot of progesterone to the female, and then we suddenly withdraw it after 12 or 13. And if bleeding occurs, then it means that the bleeding was due to the absence of progesterone, and the reason was most likely some kind of anovulatory cycle. Okay, did you get it, guys?
Yes. Mm-hmm.
Okay, now another important concept regarding anovulatory cycles is that in anovulatory cycles, just think no kind of progesterone is being secreted, but estrogen is still being formed. So, over a long course, what will happen? I told you progesterone reduces the growth of endometrium. But if the growth of endometrium is not being reduced by progesterone, then endometrial will uh, grow a lot and there will be a lot of hyperplasia and that will lead to endometrial cancer. So that is why a history of anovulatory cycles means that there is an increased risk of endometrial cancer. Remember, these are the pathophysiological phenomena that they love to ask. They want you to be very sure on these pathophysiological things. In step one, these are the very basic mechanisms, and these foundational things will go on with you in step two and step three as well. So now we'll move on to antiprogestins. So just as we discovered, and estrogen antagonists, these are the progesterone antagonists, and these are mifepristone and ulipristal. So these are the competitive inhibitors of progesterone, and they are used for termination of pregnancy. And ulipristal is used for emergency contraception. So what is the difference between termination of pregnancy? What is an emergency contraception? Anyone?
Emergency
Termination.
contraception, I think a day after someone has unprotected sex and they can
Yes.
take this emergency drug. And for abortion, is like after implantation, maybe, or some time has passed.
Okay. So if anyone remembers during the first day of reproductive embryology, we discovered that what was the day at which HCG starts getting secreted? It was the day five.
Sixth.
Was
Week
week
Day
Day
eight.
five or
six.
at six.
Eighth day.
Day six.
Mm-hmm.
It was the sixth day. Okay.
Next day.
So at the sixth day, HCG starts getting secreted. So before sixth day, if we want to terminate the pregnancy, then it will be any kind of emergency contraception because before the sixth day, implantation has not occurred completely. So we can give any kind of emergency contraception. So emergency contraception is the thing that is given after unprotected sex before day five. Okay. And if you give that thing after day five, then it will be needed for the termination of pregnancy. So keep that 5 day thing or mark in your mind that if a female is coming after 5 days of unprotected sex, we are giving her mifepristone because emergency contraception is usually useful for only 5 days. Okay. And after 5 days, we give mifepristone. Before 5 days, we will give you liprostol. Now, again, they can ask you the mechanism of action of how these drugs occur, prevent a pregnancy. So these will be very simple. They will lead to an increased uterine movements, and when there will be increased uterine movements, there will be expansion of the baby or the blastocyst. At the same time, they can tell you that it reduces the growth of endometrium. Since the growth of endometrium is reduced, the blastocyst or the embryo cannot stay there any longer. So again, there will be this problem. Okay, so now let us move on to combined contraception. So combined contraception is usually used for different things. Mainly, the number one thing that we use it for is PCOS to regulate the cycle. And again, in hormone replacement therapy, we can use combined contraception, combined OCPs, and for contraceptions, we can use it as well. So, NDMs know that that combined contraception is mainly used for contraception. So they want you to know the other things in which combined contraceptions are used, right? So, first of all, what is the mechanism of action? So, whenever we give estrogen and progesterone together, then they will cause a negative feedback loop on the hypothalamus. GnRH secretion will be decreased, LH-FSH decreases, and estrogen surge will be reduced. When there will be no estrogen surge, no LH will be present, so no ovulation will be occur. So, this is the mechanism by which estrogen work. How does progesterone works in case of contraception? So, progesterone causes a thickening of the cervical mucus. So cervix is the opening of uterus, and when cervical mucus is thickened. Okay. So remember, guys, whenever there is intercourse, the sperms are deposited in the canaliculi of cervix. So these things are known as the cervical crypts. So the sperms get deposited in the cervical crypts. They do not go up to the uterus. So after some time, the sperm starts swimming towards the uterus. But if we have given progesterone to the female in a lot of amount, so as to cause contraception, then those sperms won't be able to get to the uterus because the cervical mucus will be very thickened. So when cervical mucus is very thickened, then the sperms won't go there. Secondly, at the same time, I have already told you, progesterone will decrease the growth of uterus. So it will inhibit endometrial proliferation. So when uh, endometrial growth does not occur, the blastocyst or embryo cannot implant there. So what are the contraindications? You need to like rotely memorize this because these are very important for step one, for step two, for step three as well. Any of these simple. So people who are more than 35-year-old age who smoke tobacco, people with cardiovascular disease, migraine, breast cancer, liver disease, any of these conditions, you cannot give OCPs. You will give some form of contraception, which is hormone free. So you can give an copper IUD to that patient. Okay. So we give a copper IUD. So that is our next topic, copper IUD. So how does a copper IUD work? So copper IUD, so whenever there is a foreign body in our body, the body will produce an inflammatory reaction. So an inflammatory reaction will occur that will be toxic to sperm, ova, uterus as well. So there will be no fertilization and no implantation, and it is hormone free. So when do we use it? When we need a long-term reversible contraception, and then we use it in emergency contraception as well. Because in emergency contraception, if we can give it up to 5 days, 5 days or 120 hours. Okay, so they can ask you this number, that what is the day or number still which you can give emergency contraception in. So that would be 5 days, and specifically the most effective way of emergency contraception, that is another high yield point, is copper IUD. So you give copper IUD for emergency contraception because it is the best way of contraception. What are the adverse effects? So remember, what are the contraindications to copper IUD? The major contraindication is some kind of a bleeding of which the origin you do not know. So if there is some endometrial bleeding and you are not sure what is causing that endometrial bleeding, then you cannot give that emergency contraception,
And
the copper IUD in that case, right? Second thing is that if there is,
if uh,
yes,
and in if some patient has the uterine fibroids, does it the
okay,
contraindication also?
okay, okay. So guys, there are three kinds of uterine fibroids. Okay. So the number one, so there are three layers of uterus. The number one layer of uterus is endometrium. The second is myometrium. Okay, and the second, so the third one, and then when there will be a serosa, right? So if the uterine fibroids are submucosal, because either they are present in the endometrium or they are present in the myometrium, then you cannot give copper IUD, okay, for the treatment. But if they are because then they will protrude through the uterine cavity, and they will cause the IUD to go down. But if the uterine fibroids are subserosal, subserosal means just below the serosa, so they are towards the outer surface of uterus. In that case, we give a progestin IUD, because progestin IUD will be very favorable in that case, and it will lead to a reduced risk of reduced risk of uterine fibroids, and even it will stop uterine fibroids, because uterine fibroids are highly estrogen sensitive. So when we give those progestin IUD, it will cause it to become smaller. Okay. So in subserosal fibroids, we can give progestin IUD, but in a case of submucosal fibroids, we do not, or submural fibroids, we do not give IODs. Okay. The major contraindication is any kind of bleeding disorder. So if endometrial hyperplasia is present, first of all, you will find out the cause of endometrial hyperplasia, and only then you can give a copper IOD. And in active PID, we do not give IOD as well, because active PID, because in active PID, IOD will serve as a foreign object, and there will be a lot of proliferation on bacteria on that IOD, and that will cause problems, right? Okay, tocolytics. So what are tocolytics? Tocolytics are any drug that causes the movement of uterus to be diminished or get very reduced. So what are the drugs that can cause tocolysis, and why do we use tocolytics? So we use tocolytics to prevent premature labor or to reduce the premature labor. So if a female is getting a labor or uterine contraction in 32, 33, 34, 33rd or 32nd week of pregnancy, then we give tocolytics, right? So what are the tocolytics that we can give? We can give terbutaline, so that is a beta 2 agonist, nifedipine as well, it is a calcium channel blocker, and calcium will increase the movements of uterus, because calcium is needed for the contraction, and endomethacin can be given as well. So where they can give you a question and they can ask you that a female was in need of food, was in need of tocolysis, and we gave that female endomethacin, that is an NSAID. So what side effect do you think that can occur in that female who was given endomethacin? Anyone?
It
PDA, patent ductus arteriosus to the
endomethacin is given.
Any other side effect? Okay. So remember, endomethacin is an NSAID, and NSAID reduces the function of kidneys, not only in the female but in the uterus as well, but in the fetus as well. So when the kidney function will be decreased in the fetus, less amount of urine will be produced, and that will lead to oligohydramnias. So endomethacin carries the risk of oligohydramnias. The fetus, they will be risk of oligohydramnias. Why do we tocolytics? So the tocolytics are mainly given to give us enough time for the admission of steroids, because I have steroids. If steroids occur, and if the maturation of lungs won't occur, acute respiratory distress syndrome will occur. So we need some time for the steroids to be administered, and then the tocolytics will be given till that time, so that ARDS does not occur. Okay. So now we will move on to danazol. Danazol. Okay. So now danazol is a SARM. So we have studied about SARM. So SARM was a selective estrogen receptor modulator, right? It acted as a selected agonist at some points. What is a SARM? SARM is a selective androgen receptor modulator. That it is a synthetic androgen that acts as a partial agonist at the androgen receptors. So it will act as a partial agonist at the testosterone receptors. Okay. So where do we give danazol? So the main thing that we use danazol is for endometriosis, right? Will danazol not that much. Right? So now testosterone is a we mainly use it for today. 9% of the testosterone
Sir, your
today
voice is
is used.
constantly breaking. Your voice is
Uh,
constantly breaking, sir. Hearing.
Yes, can
okay,
you
wait.
please repeat what you said? Can you
Okay,
repeat?
can you hear me now?
Yes.
Okay, so guys, testosterone. What is the main clinical use? The main clinical use of testosterone was for the treatment of hypogonadism. But 99% of the testosterone is used for one thing only, and it is the most important drug that can come in pharmacology of reproductive system, and that is steroid abuse. Okay, so mainly the testosterone is used for steroid abuse by the bodybuilders. So how do we suspect steroid abuse? So if a young male, so there will be a young male, the NEMS will give you a 22 to 30, 27, 28-year-old male that comes to you with problems of anger, aggression, and acne on his face. And at the same time, his hemoglobin will be increased as well, right? So these are the things in which a patient of androgen abuse will come to you. And then they will ask you to diagnose this problem. Okay, so a young male with increased hematocrit, increased hemoglobin, and at the same time some kind of acne with temporal baldness coming to you uh, with aggression as well will be a characteristic telltale case of androgen abuse. Okay, so now we are moving on to anti-androgens. So
Excuse me.
abiraterone, yes.
Apart from all other things, sir, why the hemoglobin would increase over taking testosterone and exogenously?
Okay, so okay. So whenever we are giving testosterone to the male, to the people, right, increased muscle mass will develop. Okay, the metabolism increases a lot when a patient is having testosterone. Just using testosterone will lead to an increased 20 to 25% metabolic rate in a male. So when the body's metabolic rate increases 20 to 25%, the body's demand is increased. So it's just like you are adding a turbocharger to your car. So you are adding a turbo engine to your car. And when a turbo engine is added and the car's horsepower or your car's speed is increased from 200 to 300, now you will need more fuel, right? So the more
Yes, sir.
fuel is oxygen. So in order to carry more oxygen, you will need more hemoglobin. So there will be less oxygen, there will be hypoxia. And the main indicator or the main thing that leads to more erythropoiesis is hypoxia. So hypoxia is the major factor that leads to more erythropoiesis. So since hypoxia will be present, the body will form more red blood cells, and when more blood cells will form, more hemoglobin will be formed. So the patient will have increased amount of hemoglobin. Okay, did you
Yes,
get it?
yes. Thank you so much.
Okay. Yeah. Okay, so abiraterone, I think you guys can skip abiraterone. It's not that important. The important is finasteride. So finasteride is an alpha 5 alpha reductase inhibitor. It so what is 5 alpha reductase enzyme? 5 alpha reductase is the enzyme that is present in the prostate, and it converts testosterone to dihydroxytestosterone. Okay. So when testosterone is converted to dihydrotestosterone, the most two important thing that occur with dihydrotestosterone is it leads to an increased formation of prostate tissue, and at the same time it causes male pattern baldness. So in order to treat these two conditions, we give 5-finasteride. Flutamide and bliglutamide, again, they are inhibitors of testosterone, and we use them for prostate cancer because prostate cancer is hormone sensitive. Ketoconazole is an androgen synthesis inhibitor, and we use it for prostate cancer as well. You do not need to remember the 17 alpha 1 hydroxylase 1720 lyase inhibitors. These are the name of the enzymes that lead to specific steps in the formation of testosterone. You can just remember it is an androgen synthesis inhibitor. Spironolactone is an androgen receptor and synthesis inhibitor. So this is the very important thing about spironolactone. Spironolactone is that enzyme that causes the reduced synthesis as well as reduced function of testosterone. So it acts in a dual way. Okay. And we give it for the treatment of hirsutism in PCOS. So if any woman is coming to you with increased chin hair or any kind of hair, then that condition is termed hirsutism, and we give spironolactone for that condition. So now let's move to tamsulosin. The side effects of these are not that much important. You just need to remember the spironolactone is used for the treatment of is used as a diuretic as well. And spironolactone has the advantage of reducing the mortality in case of heart failure. So if the patient is having heart failure or myocardial infarction, spironolactone reduced to improve leads to improved outcomes in health and reduces mortality in the case of myocardial infarction or heart failure. Now we move on to tamsulosin. Tamsulosin is an alpha-1 antagonist. We have already discussed that. Okay. And it is selective for alpha 1A, 1D receptors in the prostate, whereas the vascular cells have alpha 1B receptors. So, what is the major benefit of tamsulosin? NBMs will ask you this. So, the major benefit of tamsulosin is that since it is specific for receptors in the prostate, it won't lead to hypertension. Because just imagine, benign prostatic hyperplasia is usually present in aged males which have age of more than 60 or 65. So in those males, hypertension is usually present. So since hypertension will be present, they will already be on 2 to 3 antihypertensive drugs. So you cannot give another drug that reduces blood pressure as well, because in that case, a lot of blood pressure will be reduced. And in old males, there is a risk of orthostatic hypertension as well. So we need to give a drug that does not affect the blood pressure. So tamsulosin is a very good drug because it acts only on the receptors in the prostate. It does not act on the receptors in the vessels. So it is a selective drug. So it after that it decreases the smooth muscle tone and the urine flow will increase. So minoxidil is an arteriolar vasodilator. Whenever we use minoxidil at some point, it causes arterioles, that dilation of arterioles, and we use it to treat male pattern baldness. And the second thing is severe refractory hypertension, but that is not the main use. The main use of minoxidil is to reduce the male pattern baldness, which is known as androgenetic alopecia. So, how does minoxidil works? Minoxidil increases uh, the flow of blood in the blood vessels, and when the flow is increased, more amount of nutrients, more amount of blood goes into those areas, and when more amount of nutrients and blood go into those areas, there will be increased growth of blood there, of hair there. So there are two drugs that we use for male pattern hair baldness. One is minoxidil and the other is finasteride, right? So does anyone have any question?
Yes, I would like you to repeat that of Danasol when you were talking about endometriosis. Your line was breaking, so we couldn't really get that. Thank you.
Okay, so I told you that SERMs are the drug that act selectively on uh, estrogen receptors, right? Okay, so SERMs are the drug that act selectively on the estrogen receptors. So adenosole is a drug that acts selectively on the androgen receptors. Okay, did you get my point?
Yes, yes, thank
Okay,
you.
so now let me tell you what happens is that danazol will act on the pituitary and it will lower the LH and FSH, and in that way endometriosis will be treated. But it is a drug that we do not use a lot in normal practice. But it's like clomiphene that, so basically it's the reverse of clomiphene. Clomiphene antagonizes the hypothalamic receptors to increase FSH and LH, whereas danazole agonizes the receptors to decrease FSH and LH. Okay.
Yes, sir. And sir, one thing I missed that point. What was the normal physiology of GnRH?
Okay, so normally GnRH, when we use GnRH in a pulsatile way, GnRH will increase FSH and LH. Okay, so that is the normal method by which GnRH acts. But if we give GnRH continuously, then it will lead to decreased formation of FSH and LH. So yeah, we can give it in two ways. We can give it pulsatile in the pulsatile form to treat infertility. In that way, FSH and LH will increase. But if we use it continuously, then it will decrease FSH and LH, and then estrogens and other things will be decreased. But the main side effect in that manner will be that it will lead to osteoporosis.
Okay, sir. Thank
Okay.
you.
Welcome. Does anyone has any other question?
No, sir.
Okay, thank you. Okay, so guys, have a good day. Take care and be sure to memorize these topics as well. Let me check the. Okay.